Alright guys, so what is an EKG? Why do we care? And what are a few odds and ends? What is an EKG? It's a picture of how electricity moves in the heart. So we got our camera over here and it's looking at the heart, and when it takes a picture, this is what the picture looks like. Right? It's showing you what the electricity in the heart has done over the last 10 seconds. This is something that may show up on your EKG certification test. This is Dr. Waller. He was studying dogs and he realized that the way the heart works in a dog is the heart uses electricity to get all the heart muscles on the same page. Well, Dr. Wilhelm Ivantoe said, you know what? That's probably how it works in people. I need to develop a machine so that we can easily record what's going on with the heart's electricity. And this is what he thought was an easy way of doing it. Obviously, we got better machines and equipment now. Dr. Perkins, why on earth do I need to care about an EKG? Look, I'm not going to be a cardiac surgeon. I'm not going to do heart transplants. I'm not even going to be a cardiologist. The only thing I need to know about is cardiac arrest. If I can identify cardiac arrest and do CPR, I'm doing pretty good. That's kind of like somebody in Japan saying, look, why do I care about earthquakes? They don't hurt anybody. They don't break anything. Our buildings are well made. It's not an issue. What we need to worry about are these tidal waves right here. This is what kills. This is what injures. Well, if you understand about earthquakes and tsunamis, you realize that this earthquake that doesn't do anything is triggering this tidal wave. And that if you recognize the earthquake, you got half an hour to get to safety. You got an hour to get to safety before that tidal wave hits. The same thing holds true of cardiac arrest, right? That code blue, if we could recognize the things that led to code blue, and we could do something about the things that lead to code blue with that cardiac arrest, we could get rid of a whole lot of code blues. So the number one cause of code blue in America is having a heart attack, right? So what happened? Part of your heart muscle died because it had either too much work to do or not getting enough blood flow. And so the classical symptoms of that crushing chest pain, oh my goodness, I'm going to die, I can't breathe, right? Those are classic symptoms. And what makes it difficult is for every one case of heart attack with that story, you're going to get diagnosed 2 cases of something else. So we need a quick, easy way, a cheap way to figure out, are they having a heart attack or not? And that's where the EKG comes into play. Even if we could figure out whether or not they're having a heart attack without an EKG, that EKG is still going to play a critical role people that are having heart attacks. Why? Well, if I have a heart attack, what kills me isn't that I lose so much muscle that my heart's not pumping out enough blood, right? Yes, I lose some muscle. That's not good. But what kills me is that the muscle that's dying starts to quiver, and it makes the rest of the heart quiver. And so instead of pumping blood, the heart quivers, and that's what kills. And so that EKG is going to help us manage that so that does not happen. We understand the heart quivers, but if we can recognize that right away and snap that back into place, or stop the heart from quivering because, hey, look, your heart's doing weirdo things and it will quiver unless we do something about it, that's going to be key. The last thing that the EKG is going to help us do is pick up on heart attacks in patients that have weirdo presentations, right? So you got the chest pain, the shortness of breath. Oh my goodness, I'm going to die. That's pretty clear. But in somebody with diabetes, somebody that's old, somebody with kidney disease, they might not show up that way. They might show up as, I'm just tired. I just need to lay down, take a nap. I was out walking with the grandkids. It was a hot day. I fainted a little bit, but now I feel fine. I'm just tired and need to go to bed. And Grandma goes to bed and she never wakes up because she was having a heart attack. That is tricky. And that is a lot of those high-risk patients. And so EKG is going to be really important in these patients. Well, what is your job as a medical assistant in terms of getting EKG? Number one, you need to be able to do it. Number two, you need to make sure that what I'm seeing here, whatever your EKG machine spits out, is actually a good picture as to what's going on with that person's heart, right? If what prints out here is not a good picture of what's going on with my patient, it's not going to help me. Number three, well, now that you've established that, yes, this is a good picture of what's going on with my patient's heart, you need to be able to do some baseline analysis. Is this person going to die because of what I'm seeing on this picture? Is this person likely to have major issues because of what I'm seeing on this paper? And if you're able to say, hey, look, this isn't normal, I think this is life-threatening, you need to get a hold of your doctor or whoever your supervisor is so they can come and take a look at the patient and figure things out from there, right? I'd much rather you call me, hey, Dr. Perkins, I think this person has a problem. And, I look at, nope, it's been like that for the last 20 years, than not be called while the patient's actively dying, right? Because guess what? I'm managing too many patients to be able to run to every single patient the second they sneeze, right? And so I need you to kind of be able to sort sick, not sick, sick, not sick, sick, not sick. And if you could do that, that will be a huge help. So who needs an EKG? Well, pretty much everybody will have at least one EKG before they die. Why do I say that? Well, what's the chance of you having what's called coronary artery disease? Well, what is that? Well, that means your heart arteries are so blocked it's causing an issue. Well, half of men will have coronary artery disease before they die, right? That is what triggers heart attacks. That is what triggers cardiac arrest, where the heart stops beating. And that's in half of men at some point in time before they die. It's in about 1/3 of women before they die. And that's going to be higher if you're diabetic. That's dramatically on the rise. Smokers, obese, you have a high sugar diet, more than 10% of your calories are coming from sugar. Or if you're a drinker, right? Especially if you drink a lot of alcohol. And so this is why they do a routine screening. Look, you have all of these risk factors right here. Even though you don't have symptoms, let's just get an EKG, make sure something weirdo isn't going on with your heart, right? We don't want to read about our patients in the newspaper. The other reason why we do it is, let's say you got that patient, he has some weirdo thing going on in his heart. It could be normal, it could be a major issue, right? Well, if this man's 70 years old, he's never ever had an issue with this before in his life, it's probably not going to kill him, right? He's probably been living with this his entire life. But let's say this man's coming in with crushing chest pain, we get an EKG and we see this weirdo thing on his heart. We're not going to say, oh, it's probably fine. No, we're going to pretend that the crushing chest pain, the thing that caused the crushing chest pain, probably caused that weirdo thing on his EKG. And so last thing we want to do is a bunch of unnecessary treatment for something that isn't an issue. Once again, that's draining time, that's draining resources from treating the real issue. And so the routine screening can help us see, hey, this is how the EKG changed. Obviously, as I said, helps us evaluate chest pain, helps us evaluate those that are undergoing surgery. And a patient that has code blue, right? They're not breathing, they're not responsive, they're literally turning blue in some cases. It's going to help us figure out what to do, right? Just because your heart isn't pumping blood doesn't mean the solution is zap them. I know on Grey's Anatomy, that's always the solution. Zap them again. But that's not always the effect. That's not always the case. And so it's going to help us figure out what to do in code blue. So types of EKG. So we have short 10-second burst EKGs, right? And these are kind of your standard EKG. This is when we're looking for something really super stupid obvious. So for example, we got a patient in front of us clutching their chest, pain's going down the left arm. Okay, so we should see something pretty obvious on the EKG if the heart is the issue. And so typically we're going to use a front-sided EKG. That's an anterior EKG. We're looking at the left side of the heart. That's the part of the heart that pumps blood to the body. If that goes down, you go down, right? We can look at the back side of the heart. That's the posterior EKG. A lot less heart attacks happen in the right side of the heart, the back of the heart, than in the front of the heart. But we can do EKG there, make sure we don't miss anything. And as I said, this is going to pick things up that are pretty obvious, that should be there pretty much continuously, all the time, right? Now, here's an issue with this. Let's say that Susie was accused of murdering her boyfriend, Bob. And so she brings in her best friend, Sally, and she says, I was with Susie for 10 seconds yesterday, and she didn't kill Bob. Well, any sort of prosecuting attorney is going to say, you know what? Let's just pretend that's the gospel. 10 seconds yesterday, but guess what? There are 86,390 seconds that are left unaccounted for. She could have murdered her boyfriend anytime before that 10-second window, anytime after that 10-second window. So you need some more defense other than that 10 seconds. And that's one of the major downsides of just their standard 10-second EKG, right? So let's say you're out mowing your yard and you passed out, right? And so that could have been your heart, but in that 10-second window that we did an EKG on you, your heart was working just fine. And so it's not going to show up. So we need a different option. Option number 2 is telemedicine. Look, I can hook you up for 24 hours. I can hook you up for 30 days. Probably you're not going to stay in my office for 30 days. I don't want you in my office for 30 days. It really isn't going to work too well for either one of us. And so what telemedicine does is it allows you to be hooked up for 30 days or however long you need to be, and then you're able to go away. You're able to live your life. You're able to go home and that sort of thing. And so this is going to be either one or two options here. Either I'm going to be watching you 24/7, seeing what's going on with your heart, or I'm only watching when you're having some sort of symptom, right? So there are strengths and weaknesses to either approach, right? If I'm watching you 24/7, I can pick up on things that you didn't even know were an issue. So for example, when you're sleeping, your heart does weirder things, I can see that. You're not going to know that when you're asleep. Now, the symptom-based approach, one of the advantages of that is going back to the idea about Sally being accused of murdering her boyfriend, Bob, right? Let's say, as I said, there are 86,400 seconds in a day. I don't need to watch all 86,400 seconds, right? Let's say she hit her boyfriend, Bob, over the head. That's the only part of that video I need to watch is when she and Bob are in the same room. When she hits Bob on the head, okay, yeah, that seals the deal. That's what killed him, right? And that symptom-based approach is, in a sense, that's exactly what's happening. So Susie's at home. She has crushing chest pain. She hits the button, and it saves the recording from a few minutes before the chest pain happened, and it's going to keep saving it for a few minutes after it happens, and that's what's going to send out. And so now, as a doctor, I can look at it. Hey, look, Susie's playing a crushing chest pain going down the left arm, but her EKG looks totally normal. So, she sent me out 3 of these. Okay, I'm fairly confident that her chest pain is not being caused by the heart. Now, it could be that it actually is, right? She just had bad luck to send me the 3 times where it wasn't her heart, right? Because you can have both. You can have chest pain that's not being caused from the heart, and you can have chest pain that is being caused by the heart. So somebody that's having a heart attack can also have episodes during the day where they're just having reflux. And so that reflux this morning, then maybe some angina. So that's the situation when the heart's not getting enough blood flow this afternoon. But because you only saw the ones from this morning, you said they're okay. Last but not least is the stress test. So what is the point of the stress test? Well, when you exercise, your heart has to do way more work. And as a result, the heart needs way more blood flow to do all that extra work. But the heart can only increase its blood flow by so much. if you have coronary artery disease, the arteries in your heart are blocked off, that's going to become a major issue. And so as the heart has to do more and more work, it's only getting slightly more and more blood flow. Eventually it's going to have an issue where it's going to start having issues. Chest pain, shortness of breath, fear of dying. And so that's why Susie, she walked her dog, or was mowing her yard, she passed out with crushing chest pain, but when she went to the doctor's office and just laid on a bed, her heart was totally fine, because it was a different situation there. And so that's one of the reasons why that stress test is very helpful. And then in addition to that, it is a longer EKG, right? You're easily recording the electrical activity of the heart for 15 minutes. So very helpful little procedure. So here is your EKG. I'm going to trace this right here. So right here, baseline, the heart is doing absolutely nothing. Here is your P wave. This is your PR segment. So your P wave plus the PR segment together produces that PR interval. Where a lot of students go wrong at is they just look at this. Dr. Perkins, I found the PR interval is really short. Oh no, that's the PR segment. Right, remember, you have to include that P wave to make it the PR interval. Alright, next thing is the QRS. So this whole thing put together is called a QRS. Yes, you can break it down into pieces. This right here is the Q. This over here is the R. Right, all of this right here is going to be that R wave. And this part over here is going to be your S. Usually we don't go too far into the QRS in terms of EKG for EKG class. Usually it's good enough just to know that, hey, look, this is the QR complex. It's going to be everything from the start of this to the end of this right here. So just knowing all of this is the QRS is going to be good enough. ST segment. So from the end of the QRS to right before the T wave is that ST segment. Heart attacks is going to be raised. This is your T wave. This is going to be the end of the heart cycle, right? And then the heart goes back to just this baseline. Now, one important metric they do like to mention, although I don't use it too much in my classes just yet, is the QT interval. So it's from the start of the QS to right when the T wave ends. That's your QT interval. Well, how do these waves relate to the heart? Remember, we're taking a picture using a camera of the heart, and that picture is going to show up as that EKG. Okay, so right here, this is going to be the pacemaker. This is the SA node, and so it sends electricity to the top part of the heart called the atria. And this is going to make the top part of the heart squeeze. And while that top part of the heart is squeezing, we generate what's called the P wave. Now, what's happened at this point in time is the top part of the heart has already squeezed, but now we have to move electricity into the bottom part of the heart. And so that electricity has already hit that AV node, and that's slowly moving electricity down into the ventricles. But it's so slow, we really don't see anything. And so that's why that line is flat, because we're really not seeing anything on our EKG. Now, what's going to happen is the electricity rapidly moves down from that AV node into the His Purkinje system. This is basically the electrical network that tells the bottom part of the heart to squeeze. And so we can see the first part of our QRS right there, and as the electricity spreads to the rest of the bottom part of the heart, those ventricles, that is when we get the rest of our QRS happening. So this next thing is going to be a little bit tricky. You gotta remember something I've said multiple times now, right? What does the EKG measure? The way electricity moves in the heart, right? And so what's going to happen? Well, the electricity is already spread throughout the ventricle, and that's the signal for the ventricles to squeeze. And so the ventricles have changed their electricity. As the ventricles were changing their charge, right, we saw this. Well, at this point in time, right, their charge has been changed, but it's not changing. Because it's not changing, it's not going to show up on our EKG. So that's going to be a flat line, right? The heart is keeping that squeeze, it's maintaining that squeeze. Well, now what's happening right here with this T wave? Well, what's happening in this T wave is this bottom part of the heart is changing its charge now. It's resetting itself, getting set up for the next heart contraction. And so now when the change has been completed, we're going to this flat line. That's called the baseline once again. So here are some other odds and ends that you're going to need to know as a medical assistant. What are you going to do as a medical assistant? You're going to respond to Code Blue's STAT. That means you're going to drop everything you're doing, unless you're doing CPR, stopping a bleed, or otherwise saving a patient who's actively dying, and you're going to do whatever it is, right? In this case, Code Blue. Usually that's going to involve CPR. Why? Because they're in cardiac arrest. The heart's not pumping enough blood to stay alive. As a matter of fact, usually the heart's pumping nothing if they're in Code Blue. So you're going to push on their chest. You're manually beating that heart with each compression you're doing in CPR. You're trying to get enough blood flow to the heart and brain to keep them alive to defibrillate. What does defibrillation do? Well, the heart's quivering and we're zapping it back into that normal rhythm now. We're breaking that lethal dysrhythmia. And so this machine is extremely helpful because it tells you exactly what you need to do. Plug in electrodes. Attach electrodes to the patient's bare chest. Continue CPR. Stand away. Analyzing. And it will tell you exactly what to do. Push the yellow flashing button. Resume CPR. Alright, that is going to be critical. Now, other things you can do is you can consider being an EKG monitor technician. Alright, they're the people that sit and look at the electrical activity of the heart all day, every day to see if somebody's going into a life-threatening situation. They could also consider being a cardiovascular technologist, so the person that does the ultrasound and so on. But one of the huge things medical assistants, nurses have to do, it's the bane of their existence, they have to take vitals. It doesn't sound like it's important, but incredibly important. Right there, we can predict several hours in advance who's going to have a heart attack, and quickly responding to patients that have messed up vitals can be the difference between life and death. So how do you take a pulse? So what you do is you take your hand, slide it along the arm, and right before you get to the wrist, on the thumb side of the wrist, you're going to kind of feel a tapping against your fingers. And that is what you're feeling with the pulse. Typically, it's going to be about 60 to 100 times a minute. You want it to be regular, right? So bump, 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 right? I know when the next one's going to occur. I don't want bump, 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 thump, thump, right? I don't know when the next heartbeat's going to occur. That's an irregular heart rate, right? The other thing is, what does it feel like? That's a little bit more subjective. Is it very easy to find or is it very hard to find? And that can kind of give us an idea as to what else is going on. Next thing we're dealing with is blood pressure. So we're on to the next topic, which is blood pressure. So everybody knows that the ideal blood pressure is 120/80. Well, not quite. More on that in just a second. But anyways, what does it mean, a blood pressure 120/80? Is the blood pressure 120? Is it 80? Is it 120 divided by 80, which would be what? 1.5? What? I'm not sure. It's kind of a little crazy here. So what it means is that your blood pressure is always going up and down, up and down, up and down, right? So your blood pressure will drop to as low as 80, but then when your heart pumps, it increases your blood pressure all the way up to 120. And the second it relaxes, that blood pressure starts dropping like a rock back down to 80. And so we're constantly switching back and forth from that high blood pressure of 120 back down to that low blood pressure of 80. So how do we measure it? Because that's going to be very, very key. Well, what we use is a blood pressure cuff. Now, the fancy word for that is the sphygmomanometer. And so we're going to wrap that thing around your arm. Now, what I teach my students to do is really simple, really straightforward. Use a measuring tape, because the blood pressure cuff will say, hey, it's good if your arm is between 20 inches and 40 inches. All right, we'll just wrap a measuring tape around their arm. Is their arm between 20 and 40 inches around? If not, then your cuff is either too big or too small, and it only took a second to do. Right? Really simple. All right, next thing you're going to do is you got to have the cuff properly positioned. And so they're going to have like a line on the blood pressure cuff and say, hey, we want this line over the brachial artery. So you're going to feel for an artery around their elbow. And once you've found that, you want the blood pressure cuff to be about 1 to 2 inches above that, and you're going to pump up the blood pressure cuff. And so now that the blood pressure cuff's been pumped up, the pressure on that artery is greater than the pressure of the blood to try to open up that artery. So that this artery is always closed. Why? Because at no point in time is the pressure of the blood equal to or greater than the pressure of that blood pressure cuff. Well, once I get here, the pressure of the blood pressure is higher than the pressure in that artery. So that artery is going to open up. Now we're not getting very much flow at all, so the flow is going to be low. It's going to sound like a tapping noise, right? And at first that tapping is going to be very faint. So this is why they tell you want to do blood pressure in a quiet room, right? It also is important to be aware if you're losing your hearing. Why? Because if you're losing your hearing, you're not going to hear this, right? Anyways, as the pressure in the blood pressure cuff drops, what's happening? Well, we're allowing more and more blood flow into the artery. So it's now going to be, right? It's going to get louder and louder because we've got more turbulent blood flow. And so it's going to keep getting louder until the artery is about half blocked. Now, at this point in time, as we continue to drop the pressure in that blood pressure cuff, what's happening? The blood flow is becoming less and less turbulent in that artery until the artery is completely open, right? That blood pressure has dropped, the blood pressure cuff's pressure has dropped so low that that artery is always open no matter what. And at that point in time, you're not going to hear any more heart sounds. And so your systolic blood pressure is the first tapping noise you heard, and the diastolic is the last tapping noise you heard. And so this case would be, we're saying that we heard it at 120, and we said that the last noise went away. When we look over here, it's saying the pressure was 80. And so that's how they come up with that blood pressure of 120 for 80. Where things go haywire is, let's say you had bad hearing. And so you can only hear when the noise is out, right? And so you're going to say, oh, look, this person has a blood pressure of 110 because you're only able to hear this noise over here. And yep, the noise went away over here. And so when I follow this over, we'll say about 90, right? So be aware, make sure that your hearing is good because it will throw off your numbers. Next thing we're measuring is that respirations. And so respirations is just a fancy name of breathing. So you're breathing in and out, right? If the patient is breathing like this, that might be a normal respiratory rate, but that is not a normal breathing pattern, right? There's way too much work. And that's one of the things we're looking for, not just the rate, but how much are they breathing. So different places will tell you different things, 12 to 20, 12 to maybe 25, but roughly in that ballpark, 16 to 18 is going to be more ideal for an adult. That's what we're looking for. The other thing is the pulse ox, right? What is that looking like? It normally should be 95% or higher, and that means 95 out of 100 of the red blood cells are carrying oxygen. Now, temperature. What is their body temperature at? Well, 98.6 is ideal, but you got some wiggle room right here, right? You got plus or minus 1.8 degrees Fahrenheit. So you're allowed to get as high as 100 decimal point 4 or as low as 96.8 before we start getting worried, right? If you're at 100.4 for more than an hour, we say that you got a fever. If you're below 96.8, you're actually in hypothermia, right? You're too cold. Now, the next one is going to make people want to cover their ears. It's your weight. And unfortunately in America, obesity is a major issue. And a lot of people are in denial about being obese. So being obese is having a BMI greater than 30. Basically what you need to do is you need to take how much you weigh in kilograms and divide it by your height in meters squared. If you don't have the math skills for that, don't worry about it. There are online BMI calculators, right? But it's going to tell you basically how much you weigh, and we're able to compare that to somebody your height, because that's a major risk factor for lung issues such as sleep apnea, liver disease, gallstones, arthritis, cataract, stroke, cancer, heart disease, diabetes, pancreatitis, gout, and even death. Right? And they say about 1 out of 5 deaths in America are linked to being obese. So that's a major issue. That's definitely something we want to look upon. Now, one of the vital signs in air quotes here is actually pain. The reason why I say air quotes is pain is actually not a sign, right? There's no painometer. I have to go with what you're telling me. It is a symptom, right? It's just like, for example, with the dog, do you know whether or not your dog has pain, right? They might be running around playing just fine, but actually in a lot of pain. And so a symptom is something the person feels. Doesn't mean it's not important. It's just it's something the patient feels. So it might be a vital symptom, but it's not really a vital sign. But that being said, you definitely want to ask about that. All right, so how to avoid getting sick? Well, what you're going to do is you're going to take the standard precaution. That means you're going to pretend that all bodily fluids are potentially infectious, right? So you're going to pretend that if I see this blood, it has Hep B, Hep C, HIV. All right, now also be aware of isolation precautions. One of the things you have is airborne. So if you're in the same room as this person, you can get their germs. And some of these germs can hang around for a long time. So for example, like tuberculosis, it's a really bad cold where you right? And so now, I've coughed, I put my tuberculosis in the air, and I may have left the room, but you can still catch my tuberculosis up to 8 hours later. So definitely make sure you're wearing a mask when you're going in that person's room. Droplet precaution. This was the whole Corona crazy situation. If you get within 9 feet, not 6, 9 feet of somebody that has a droplet infection, you need to wear droplet precaution. So you're wearing a mask. All right. Now the mask is not 100%. So for example, with COVID, if you would have breathed in 100 COVID particles without a mask, you're going to be breathing in about 80 with a mask. So when you see your patient, you're not going to be hanging out talking for a long period of time. You're going to get in there, talk to the patient, get done what you need to do, and then leave, because you don't want to get their illness. The other thing that you need to do is contact precautions. So anything they touch or you touching them can make you sick. So, anybody that has these airborne or droplet precautions, just assume they have contact as well, right? So you're washing your hands with soap and water. So you're wearing gloves. When you get done, take the gloves off, but wash your hands. Now, this is an alcohol-based rinse, and for most of the time, that's going to be good. But if you have a bug that's dealing with the gut, so nausea, vomiting, diarrhea, that sort of thing, this isn't going to cut it. You need good old-fashioned washing your hands with soap and water. So, for this, avoiding getting sick actually goes both ways. Not only can the patient make you sick, you can make the patient sick. And so which one is going to be more important? Well, you making that patient sick is far more important. Here's why. So look at the whole corona crazy thing. If you got COVID and you were under 40 years of age, on average, you had less than a 2 in 1,000 chance of dying. And that's with you're sick. A lot of people got sick and never knew it. And so that's going to drive the death rate from COVID even further down. Now, let's talk about people with congestive heart failure. So you're in the hospital, you're dying from congestive heart failure, really bad prognosis right here, and you get COVID. Well, out of nowhere, it's not just, yeah, I'm sick, it's not fun, but you got a 30% chance of dying from that cold. And every cold that you get is going to be kind of like that COVID, where for you, the layperson, if you're under 40, you don't really have any underlying conditions, not a big deal. But for somebody with congestive heart failure, somebody that's 85, somebody that's gone chemo, out of nowhere, those super simple infections can absolutely be death sentences. And so that's why you got to be very, very careful about following these precautions. One quick word before I move on. Clip your fingernails. Your fingernails should be no more than a 1/4 inch long, so you should be clipping them pretty much every day. Yeah, no artificial fingernails either. Now we're on to the non-medical aspects of the job, right? And a lot of people get frustrated with this, but unfortunately it's life. You got to deal with the world the way it is, not the way that you'd like it to be. So there's ethics, doing the right thing. Just because it's legal doesn't mean it's right. So you need to be aware of what is right, and then also kind of what the rules are. All right. So defamation is you're running your mouth about somebody, and if you do it in writing, that's libel. It's literature. It's written down. If you just talk about it, it's slander. It's what you say, and you can pay some serious fines for that. Next thing we have is HIPAA. And so the point of HIPAA is to enhance patient confidentiality. So keep it a secret. The thing about HIPAA is it was a law passed with good intent, but it did have some negative unintended consequences. So for example, you give your patient a good discharge summary and they go out to the car and drop it off in the parking lot, somebody reads it, you can possibly get sued for HIPAA. Sounds like a far-fetched scenario, but that exact thing happened to our family. I remember my daughter, she ended up going to the hospital, and they gave us a discharge summary, and I looked through it, it's like, what on earth is this? You didn't tell me anything about what you did, what the test results said, who am I supposed to see? I mean, this is terrible. Where's all the information in this discharge summary? Oh, we don't do that anymore. Why not? How am I supposed to know what's going on? Well, you can go on the patient portal, but we don't do that anymore because people were dropping their discharge summaries in the parking lot, and it was a potential HIPAA violation. So hospitals take those very seriously because they can be sued thousands of dollars and people can go to jail. So watch out for HIPAA. This is also why a lot of hospitals really frown on cell phone use, right? They can fire you and so on if you use your cell phone. Alright, medical liability. What can you be sued for? Unlawful acts. So let's say John's having a heart attack, and while doing CPR, you steal their credit card. Alright, obviously you can go to jail for that. You can be sued for that. Lawful acts done wrong. So, the patient's a full code, but, grandma's 90 years old. She had congestive heart failure. And, you're really just doing CPR for the family, so you're doing one-handed CPR. Not a good idea. you can be sued for that, right? Doing CPR is a lawful act, but you did it wrong, right? You should be doing CPR with 2 hands, pushing 1/3 to 1/2 the depth of the chest. You should be going at 100 to 120 compressions per minute. Right? If you're going away from that, you can absolutely be sued. Alright, failing to act when necessary. Be aware of Good Samaritan laws. Alright, so Good Samaritan laws, they protect the lay person that responds. So grandma, she has a heart attack, you do CPR on her, do it to the best of your ability, and EMS shows up, you hand off the care of grandma to somebody else, and the family member says, "Oh, thank you so much for taking care of my grandma. Here's $100. If you take that money, you are no longer protected by the Good Samaritan law, and so you can be sued, even if you did everything right. Right? So it's not that you did something wrong; it's that the patient thinks you did something wrong. So you break ribs all the time doing CPR, but you can be absolutely sued for it, even if you do everything perfect. So be aware of that. If you're doing CPR or whatever as part of your job and the patient has some sort of complication, you can be sued for it, even if you did everything perfect. So definitely pay attention to that. Last but not least, failing to act when necessary. Going back to the Good Samaritan law. So let's say you're at the gym and man next to you has cardiac arrest. You don't have to do CPR, and they cannot sue you for that. But if you're employed by the gym to do CPR and somebody going into cardiac arrest, now you can be sued. Why? Because you have a duty to act. How to avoid getting sued. This is huge. On average, doctors get sued every 5 years, and you will never win a lawsuit. And what do I mean by that? All right, the judge might say, not guilty, but guess what? You still lost the lawsuit. What? How could you have lost the lawsuit? Well, a couple of things. Number one, you lost at least one patient right there. Most patients, if they sue their doctor for malpractice, aren't hanging around and getting more medical treatment from them. Number two, other patients are likely to lose. Right? Look, I don't have all day to read about this lawsuit. Only thing I see is Dr. Smith was sued for inadequate treatment during cardiac arrest. And nope, that's good enough for me. And a lot of patients will drop based off that. Another thing is your malpractice insurance may go up. And so they're going to man, that guy just got sued. Yeah, man, that could have been really nasty. And he could have had a settlement for $2 million on that thing. Let's increase his insurance just in case it doesn't go so well next time. Thirdly, another thing that's going to happen is the doctor had to pay the lawyers. He had to take time off of work. And then there's the frustration of the whole lawsuit itself. So all of this is taking a toll on the doctor and on the practice. So in a sense, doctors never win lawsuits. The judge might say not guilty, but all these costs are still going to be there. So how do you avoid getting sued? Document, 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 document. The more thoroughly you document, the less eager a lawyer will be at suing you. The less eager a patient will be at suing you. So you're going to document the consent. Look, the patient was supposed to have open heart surgery. I told him the risk and benefits of open heart surgery. I told him the risk and benefits of doing other procedures. I told him the risk and benefits of not doing anything. And he chose open heart surgery. Now, the other thing you want to do is make sure they're not on any narcotics or any mind-altering substance, or that they're not demented, right? If the patient does not have capacity to make the decision, that consent's not going to hold up in court. The other thing you're going to document is the physical exam. Hey, this is what the patient told me. This is what we saw when we examined the patient. This is what the test results showed. This is my diagnosis and treatment plan. And any sort of back and forth, any sort of communication you had with that patient, you're going to document that. And that patient education is critical, right? Anytime you open your mouth and you tell something to a patient, you are educating them. You're setting expectations. If I'm thinking you're going to wave your magic wand to cure me, and instead I've never been the same since my heart attack, I'm going to be pretty upset, and I might consider suing. A lot of people would. So expectations are going to be key. The other thing is use words your patients know. Now, how do you know if your patient knows them? Well, you don't know 100%, right? A great method is always have your patient explain it back to you. Hey, Mr. Smith, we just talked about open heart surgery. Can you talk to me like you're talking to your wife or your kids or whoever? Oh yeah. You're just gonna put it on an operating table and you're gonna go in there and get it, and I'm gonna be back in action tomorrow morning. Okay, that person clearly didn't get it. So that could be very helpful. Another thing that's helpful with this is the words you want to use are small words. So if a word has more than 2 sounds in it, you really need to think about not using that word. Alright, so for example, electrocardiogram. What the heck is that? Right? Well, use an abbreviation, EKG. Alright, well, once again, the abbreviation makes it look easier, but actually makes it more complicated. An example I give to students. Your patient has FASD. What is the number 1 cause of it? And the students go, they have no clue. But then I ask the exact same question, but I spell out the abbreviation. Your patient has fetal alcohol spectrum disorder. And the students immediately grasp, hey, drinking alcohol while pregnant. Right? So watch out for abbreviations. Alright? Now, sometimes you're going to have to use big words around your patient and explain them. Explain them. So small words, small sentences. A small sentence is going to have less than 10 words in it. Alright? So many small sentences are better than one big sentence. So, for example, let's say we're going to do an electrocardiogram. That's a big word. Alright, so what we're going to do is we're going to take a picture of how your heart talks to itself. So it's going to let us see if part of your heart is hurt. And if so, whether or not we can fix it. That's going to work a lot better than saying, hey, we're going to get an electrocardiogram, and it's going to look at the electrical activity of the heart. Right? Electrical, that's a 4-syllable word. Chances are they're not going to know what that means. So, you could also say, hey, look, Mr. Smith, the way your heart works is it makes a zap all the time. It's constantly producing this zap, constantly making a zap. And that zap tells the rest of the heart to squeeze. And so we want to make sure that zap is moving around the heart the way that it should. And so we're going to take a picture to see exactly how the zap is moving. Your patients are going to understand that far better. All right, guys. Well, I hope that helps, and good luck.